Assalamu alaikum rahmatullahi wa barakatuh. So this is another station in oncology module. So you are about to see Mrs. Anne Cunningham. She's a 66-year-old lady who underwent a laparotomy for a complex ovarian mass 7 days ago. Her preoperative CA125 level was 40. Preoperative X-ray, chest and MRI scan did not show any extension or extra ovarian spread. At laparotomy, there was minimal ascites, but no other evidence of the extra ovarian spread. You performed a total abdominal hysterectomy, peritoneal washing, and infracolic omentectomy. Histology has shown moderately differentiated serous cystadenocarcinoma with evidence of microscopic deposits in the omentum. Peritoneal washing showed also clusters of adenocarcinoma, and this is stage 3A. She was aware of the possibility of cancer, but she was told that it was almost certainly benign because of almost normal CA125. She is still an inpatient, but she has recovered well from her surgery and is awaiting discharge. Please counsel her regarding the diagnosis and further management. Okay, so the scenario states that you have done a surgery on a patient and you and her, both of you are expecting she has a benign lesion, and now with the histology result came back as a cancer and stage 3A as well. So it's like a breaking bad news. You need to go and see the patient. You need to take a full history and again to break her the bad news in the same way as any thing. So in the history, we need to like search for the risk factors of ovarian cancer. So what are the risk factors of ovarian cancer? Usually, ovarian cancer tends to come in old age, but there is no age limit for ovarian cancer. But so if the patient is old, we expect it to be more undifferentiated or more cancerous, okay? It also relates to the parity. So when the patient having low parity or nullipara, she will be at higher risk of the ovary, because here the trauma to the ovary is monthly ovulation. So when we abolish this ovulation, the trauma will decrease to the ovary. So it's the opposite of the cervical cancer. So cervical cancer increase the risk with high parity, but ovarian cancer increase the risk with low parity. And with the same idea, there is a theory that if the woman used in the past contraceptive pills, which is inhibiting the ovulation, it will protect her from developing ovarian cancer as well. Okay. One of the risk factors, if the patient postmenopausal, you need to explore whether she's on any HRT or no, because having hormonal treatment may carry a risk on the ovary as well. And in the past, we need to be asking about any previous history of fertility treatment, because the use of induction of ovulation frequently will also cause trauma to the ovary, so it will increase the risk of ovarian cancer. And smoking can increase the risk of ovarian cancer, can increase the risk of cervical cancer as well. And all these risk factors are one side, and the other side is the main thing, which is the family history. It's very important here to ask about the family history of ovarian cancer, family history of breast cancer, family history of colorectal cancer. And actually, there is some gene mutation that may predispose to these cancers. So if the patient has BRCA1 or BRCA2 mutation, she will develop either breast cancer or ovarian cancer. If she has a mutation in HNPCC gene, this is predisposing to cancer colon and at the same time cancer ovary. Okay, so the family history is very, very important. What are the protectors from the ovarian cancer? Pregnancy, breastfeeding, and oral contraceptive pills, as I told you. Okay, so I need to ask in the history and include these things in between to be sure that she's having any high risk or no. And also I need to ask about her menopausal status and whether she has any problem after she stopped her menses, and whether she had any kind of hormone replacement therapy, what about her previous cervical smears, and if she had in the past any gynecological problem or any gynecological issue at all, any previous history of ovarian pathology like ovarian cysts or anything like that. So again, we need to ask about the effect of the tumor locally and generally. So if she has any symptoms or what happened and caused discovery of this ovarian mass. If she is presented with acute abdominal pain due to any complication in this mass like twisting or anything or hemorrhage, or she presented with urine retention, for example, because it may compress the ureter, or whether she was presented with like bloated, okay, or GIT symptoms. Usually the cases of ovarian cancer presented late because usually it will start as a GIT symptoms. Okay, so we need to explore what symptoms she's having and how this cancer affecting her general health. If she's feeling easy fatigability, if she lost her weight recently, like that. Okay, so that's how to take the history from this patient. So we need to counsel her. We need to break the news for her. So how to break the bad news for her? So after you take the full history, so you can also in the history include how she's feeling after the surgery, how she's doing, if she has any problem, have she opened her bowel and she passed urine easily, she eats and drinks well, and she can be independent at the moment, like that. Okay, so like a post-operative patient in general, you can ask about her own health as well. So Mrs. Cunningham, I can see you are alone today. Do you want to call any of the staff nurses to be with you? Because she's inpatient, she can't call someone from home to be with her. Or if anyone from her relatives is going to visit her today, we can come and meet them together. But the applicable thing is to call someone from the staff to support her. Why? Because I'm going to give you a lot of information. No, you can deliver the information or you can tell me. Then you tell her, I'm really sorry, I don't have a good news for you. We got the result of your histology and it showed that you unfortunately had adenocarcinoma and your cancer is stage 3A. She will make her own drama, she will cry, she will be shocked because she was expecting some benign lesion, and then she will tell you, why did you tell me that it's benign? Why didn't tell me that it can be like that? It can be how my CA125 is normal and I have a cancer. So how can CA125 normal and it's a cancer? So we need to tell her that the tumor markers are just a protein which may present in your blood when you have a cancer in high amount, but it is not necessarily to be raised in all kinds of cancer. And in this situation, we can't follow you up with the measurement of this protein. But anyway, we need to repeat it today because this was before the surgery. Okay, so now we both like one more week after it, so we need to measure it again today. We need to run some investigations as well because we found some nodules of spread in your omentum. So we need to run some scans in your tummy, in your chest, in your pelvis to be sure that there is no further spread of the cancer. Okay, and you can offer the counselor, you can offer the support group, and also you can offer to speak to her relatives as well if she wants, because she needs the support. And then you discuss with her the options if she's okay, options of treatment. Okay, you tell her that the best thing that you have done already is the surgery. We removed everything, and what we are going to plan for you is to give you adjuvant chemotherapy to kill the remaining cells inside if there is, to be sure that this cancer can't return back or can't recur. So she will tell you how this cancer can come back while you have removed both of my ovaries. We can tell her that ovarian cancer is not necessarily arising from the ovaries. It can arise from the lining of our tummy, which is the peritoneum. It's just a clear membrane which can have the same structure and same cell structure of the ovaries, and the ovarian cancer can come from this sheath as well. It can also arise from your colon or the fatty layer that connects your colon parts together, which is the omentum. Okay, so it is not necessarily that it can recur only from the ovary. It can recur from any other parts of membranes inside your tummy. That's why we need to give you, after you had this chemotherapy, we need to give you a follow-up plan of 5 years. We need to see you in the first 2 years after you completed your treatment, every 3 to 6 months, and the next 3 years, every 6 to 12 months, until we confirm there is no recurrence in the coming 5 years after you finish your treatment. Then you will be discharged from our care and we can confirm that your tumor has been treated. So what we need to do is to run some scans to repeat some investigations. We'll repeat the CA125, but we will add more tumor markers like CAE and CA19-9 and alpha fetoproteins. And we'll do some blood tests to check your kidney functions, liver functions, and your full blood count. Okay, so we will have a full idea about your health, and we'll run some scans to your chest, your tummy, your pelvis, maybe in the form of CT, to be sure there is no more spread elsewhere in your body, to be sure also there is no lymph node affected. Okay, so if no lymph node involvement, you may be managed by only chemotherapy, and usually we'll give you like 6 cycles of chemotherapy. The chemotherapy actually in cases of ovarian cancer can be delivered either systematically or locally. Locally is intraperitoneal, okay? But to have an intraperitoneal chemotherapy, yeah, it's more effective than if it is systematic, and the complications are much less because you are applying the treatment to the area of the cancer cells and not to the whole body. So it's the same idea as the local radiotherapy and the outside one. So if you give her the chemotherapy intraperitoneal, you will limit the effect to the tummy only, but you know, very few amount may be absorbed in the bloodstream, okay? But not like if you give it as a systematic treatment. But we have to be sure before giving this kind of treatment that she has a normal kidney functions and she has no adhesion inside, because if the patient having adhesion and you put the chemotherapy intraperitoneal, this adhesion may be like a barrier and preventing the chemotherapy from reaching the cancer cells, and we are treating it locally only, not systematic. So it has to reach each cells in her tummy. So she doesn't have to have any adhesion inside. She has to have a normal kidney, okay? And she may expect, of course, some abdominal pain and some vomiting as well, okay? So if she is taking it as a systemic, it will be delivered by intravenous route, and she will need like 6 cycles. And we will also see her and see how she is responding to the chemotherapy. In certain situations, if we know or if we expect from the start that we may have a malignancy inside, we may start the chemotherapy before the surgery to reduce the size of tumor. This is not in our case, but that's for your knowledge. We may give her 3 cycles of chemotherapy, then she will have the surgery, then after that another 3 cycles of the chemotherapy, and then if everything is fine, then we will plan for her follow-up. Don't forget to talk about the MDT referral after you finish your breaking bad news to her. And if she asked what will be my management, you need to tell her that your management will be decided by the multidisciplinary team, which is a team. They will conduct a meeting, okay? And we will send your notes and investigations to them. They are a group of consultants of different specialty who are specified in these kinds of tumors. They will see your investigations, review your notes, and will decide what is the best option for your treatment, whether you need another surgery, whether you need to take a chemotherapy intraperitoneal, whether you need to take a chemotherapy as a systemic, whether you don't need any further treatment, and the decision after that you will be given an appointment to come and know the final decision of the MDT, and then the decision of the treatment, either to agree or to change it, is up to you after knowing all the risks and benefits of these choices. By the meantime, you can discharge her even from the hospital. If the MDT meeting is far, she can be discharged, and you book for her an appointment on the day of the MDT meeting to come and know the decision. Otherwise, if the MDT meeting is very soon, like if in our hospital they conduct the MDT meeting on Monday, so if she is here and today is Monday and she's about to be discharged, there is no need to discharge her. She can wait until the decision and then she can go home. Or if like still one day waiting for the MDT and to be conducted, so she can wait. But if it is today, for example, Tuesday, and the MDT meeting is next Monday, then she can go home if she feels okay, and then she come next Monday to know the decision. Before sending these kind of patients home, we need to be sure that she can take care of herself. She has a good support at home. So if you take the history from this lady, she will tell you that she's alone, she's living alone, and she doesn't have anyone to live with. So don't discharge her from the hospital until you arrange for her some healthcare assistant or someone who can take care of her until she become freely independent and can take care of herself. Okay, so that's it. It's just to like a Breaking Bad news station, but we need to be aware of the risk factors of ovarian cancer to take the history. We need to counsel her about the mode of treatment. MDT team, don't forget to refer any oncology patient for MDT, because this will count as a communication with colleague. Okay, thank you.